Hello, my name is Mary McCarley, and today we will be discussing the comorbidity of dyslexia with depression or anxiety. The topics we will cover include a background, the relevant definitions and characteristics of dyslexia, depression, and anxiety. We will discuss the relevance and why comorbidity even matters. We will review empirical evidence, looking at studies and results of comorbid relationships. We will also review variations in symptoms, which can influence the severity of comorbid symptoms. We will discuss the emotional and academic impact, as well as the social impact, and then also review treatment and prevention options. Lastly, we will conclude with what we should do next with this information you will learn. Now we will discuss the background, including relevant definitions and characteristics of dyslexia, depression, and anxiety. Let's begin with dyslexia. Dyslexia is characterized by difficulties with accurate and/or fluent word recognition and by poor spelling and decoding abilities. These difficulties typically result from a deficit in the phonological component of language that is often unexpected in relation to other cognitive abilities and the provision of effective classroom instruction. This means that in order to be diagnosed with dyslexia, students must be provided accurate and effective instruction. Characteristics include difficulty with word recognition and decoding. It impacts spelling and reading fluency. It persists across the lifespan. It has a genetic basis. There are problems in reading comprehension. There are reduced reading experience overall, and it impedes the growth of vocabulary and background knowledge. Next, we will discuss major depressive disorder. Depression is a mood disorder that causes the persistent feeling of sadness and loss of interest. It affects how you feel, think, and behave, and can lead to a variety of emotional and physical problems. You may have trouble doing normal day-to-day activities, and sometimes you may feel as if life isn't worth living. Characteristics include feelings of sadness, tearfulness, emptiness, and hopelessness. There are angry outbursts, irritability, or frustration. There's a loss of interest or pleasure in most of or all normal activities. There are sleep disturbances, including insomnia or trouble sleeping too much. There is tiredness and lack of energy, so even doing small tasks take extra effort. There's also reduced appetite and weight loss, or increased cravings for food and weight gain. People with depression feel worthless or guilty. They have trouble thinking, concentrating, making decisions, and remembering things, and frequent or recurrent thoughts of death, suicidal thoughts, suicide attempts, or suicide. Next is generalized anxiety disorder. Generalized anxiety disorder, or GAD, usually involves a persistent feeling of anxiety or dread, which can interfere with daily life. It is not the same thing as occasionally worrying about things or experiencing anxiety due to a stressful life event. People living with GAD experience frequent anxiety for months, if not years. People with GAD have troubles feeling restless, wound up, or on edge. They can become easily fatigued. They have difficulty concentrating. They might be irritable. They might have headaches, muscle aches, stomach aches, or unexplained pains. And they can also have difficulty controlling feelings of worry. They also might have sleep problems, such as difficulty falling asleep or staying asleep. We will discuss some other important terms which will come up a lot during this presentation. Number one being comorbidity. Comorbidity is the simultaneous presence of two or more diseases or medical conditions in a patient, meaning while they suffer from one disorder, they also have to suffer from the symptoms of a second or another. Internalizing behaviors are actions that direct problematic energy towards the self. To contrast, there are externalizing behaviors, which are actions that harm others, as opposed to lashing out at the self. And lastly, we will cover specific learning disability. SLD is a disorder in one or more of the basic psychological processes involved in understanding or in using language, spoken or written, that may manifest itself in the imperfect ability to listen, think, speak, read, write, spell, or do mathematical calculations. Now, why does this topic matter? Understanding comorbidity allows us a better understanding of specific treatment approaches. Remember, comorbidity is having two disorders at the same time. So an individual with comorbid symptoms will have symptoms from one disorder and a second one. Understanding this relationship allows us to better treat the individual. Additional disorders can affect the expression and severity of dyslexia, such as more severe neurocognitive impairment, negative academic experience, negative social outcomes, lower treatment response. We will discuss other influences on the severity of dyslexia later. Comorbid problems also bring secondary issues, such as low self-esteem, behavioral problems, and dropping out of school. Comorbid relationships have a widespread prevalence. 1 in 10 students have a reading disability, and dyslexia is the most common learning disability. Neuropsychiatric diseases, especially learning disorders such as dyslexia, have high rates of comorbidity during developmental age. Over 60% of children with dyslexia meet the criteria for at least one additional diagnosis. And even for those who do not meet criteria, individuals with dyslexia may still experience severe emotional problems. We will discuss the depressive and anxious symptoms in individuals with dyslexia, even if they do not meet the criteria for diagnosis. There are severe consequences to comorbidity. Dyslexia contains severe risks for increased internalized symptoms, especially anxiety and depression. 16% of students aged 7 to 14 with dyslexia chose the answer in a questionnaire, "I think about killing myself, but would not do it." This is compared to a control group in which 0% responded, "I do not think about killing myself." Other studies found a 10% frequency of this answer in other control groups without learning disabilities. Another study found that adolescents with reading difficulties are at 3 times more risk for suicidal thoughts and acts compared to those without reading difficulty. Dyslexic individuals also have much higher rates of mood disorders, twice as likely, and anxiety disorders, 3 times as likely than non-dyslexic individuals. Now we will discuss the empirical evidence, looking at the results in the specific studies of comorbid relationships between dyslexia and anxiety or depression. First, we should make a very important distinction between correlation and causation. Correlation is just the association of 2 variables. Causation involves the association of 2 variables, as well as the preceding of an independent variable before the dependent variable, and a proven absence of a third influential variable. Causation is much harder to prove compared to correlation. But even without proof of causation, correlation data can still be very useful, especially in dyslexic cases. The data can provide indication of risk factors, including psychosocial discomfort. Clinical specialists can then better target and prioritize intervention for children with greater risk of depressive and anxious comorbidities with dyslexia. And support systems can better monitor, control, and reduce psychological ramifications prior to occurrence. Now we will discuss hypotheses of causation between dyslexia and depression or anxiety. Causation has not yet been established between depression or anxiety with dyslexia, but there is strong evidence for correlation. Susceptibility to depression and anxiety could result from negative impact of learning difficulties associated with dyslexia. This hypothesis has a lot of support, and we will explore this further, especially during our activity. Academic failure can lead to negative internalizing symptoms, leading to development of depression or anxiety. Self-efficacy, self-concept, and self-esteem impairments for individuals with dyslexia frequently report depression and anxiety comorbidity. Other hypotheses suggest that anxiety and depressive disorders could interfere with academic work, causing dyslexia. Some researchers propose anxiety disorders specifically interfere with cognitive processing and reading, causing the reading disorder. For individuals with dyslexia, depression, and anxiety, all three disorders, researchers suggest the depressive symptoms are a result of anxiety. Other hypotheses explore a reciprocal causality and an unknown third variable of causation. It is challenging to define a causal factor, as all three disorders have very similar effects on overall mental health. Let's discuss specific empirical evidence of dyslexia comorbidity with anxiety disorders. Multiple studies have supported a significant correlation of increased generalized anxiety and reading disorders in comparison to individuals without learning disorders. This correlation persists even in studies controlled for ADHD symptoms. Studies have also confirmed a bidirectional relationship between anxiety and reading. One thing that is important to note is that there is uncertainty of the precise nature of anxiety disorders when comorbid with reading disorders. Some suggest that comorbid anxiety could be generalized disorders or reading anxiety, which is specific anxiety as a result of reading. Previous research has found a neural and behavioral distinction between general anxiety and mathematic anxiety. Both disorders have similar characteristics, but are distinct nonetheless. This suggests a possible distinction between general anxiety disorders and reading-specific anxiety. Contemporary research in the field should focus on determining a method for evaluating reading anxiety specifically, so that education and clinical sectors can better target intervention for dyslexic and anxious comorbidities. For our audience specifically, district leaders and educators should therefore continue studying new empirical evidence of this distinction. Now let's discuss dyslexic comorbidity with depressive disorders. Multiple studies have also found a significant correlation between rates of depression and reading disorders. Evidence shows a significant correlation between young individuals with more severe reading disorders and greater depressive symptoms. That means the harsher and more severe the reading disorder, the harsher and more severe the depressive symptoms. This evidence also persists even when ADHD symptoms and social desirability factors have been controlled. One study found that low self-esteem, a common symptom of both depression and dyslexia, predicts 23% of depression risk. This suggests that low self-esteem could be a target for intervention. We will explore this topic later. Both reading disorders and depression exhibit patterns of heritability and marginally significant genetic contributions. However, this connection could instead be a result of environmental factors or could be exacerbated by environmental factors. Students with reading disorders experience higher incidences of bullying, which could cause depression. More contemporary research focusing on neurodevelopmental risk factors indicates a possible impairment of emotional processing in children with reading disorders. New methodology is required in order to confirm this, as the lack of understanding emotions could result in unreported symptoms for self-report measures. This could lead to a more accurate assessment of comorbid depression and anxiety for those with reading disorders. This presentation will establish multiple connections between dyslexia and internalizing symptoms, which are typically associated with depression and/or anxiety disorders. Research has supported these findings, finding significantly higher mean scores of subscale withdrawn, anxious, attention, and delinquent in dyslexic individuals. There are also significantly higher scores in internalizing, externalizing, and total problem mean scores. These findings further support the correlation of dyslexia with depression and/or anxiety symptoms. Let's look at a specific case study of comorbidity of learning disorders with neuropsychopathological disorders. Marjorie et al. Studied 448 subjects with learning disorders. They evaluated familial, physiological, pathological, academic history, and examined physical and neurological health. Subjects were placed into two subgroups: specific learning disorder, including reading, writing, and calculation disorders, and learning disorder not otherwise specified. All individuals were Caucasian, aged 7 to 16 years old. There were 319 males and 129 females. The study found 62.2% comorbidity with neuropsychopathological disorders in the total sample. Of the specific learning disorder group, 28.8% presented anxiety disorder, 9.4% presented a mood disorder. Remember that depression is considered a mood disorder. Of the learning disorder not otherwise specified group, 16.4% presented anxiety and 2% presented a mood disorder. In the specific learning group, frequency of comorbidity of anxiety and mood disorders was determined significant. In analyzing the results, researchers referenced an hypothesis of a bidirectional relationship between anxiety, depression, and academic achievement. The authors attributed anxiety and mood problem development to negative academic experience in students with learning disorders. The authors also proposed that anxiety and depressed moods could be impacting academic experience. Due to the nature of dyslexia, anxiety, and depression, it can be difficult to establish the preceding variable, which would be necessary to conclude a causal relationship. The study does, however, establish a correlation between learning disorders with anxiety or mood disorders. Neurodevelopmental longitudinal studies will be required in order to make a decisive conclusion on the relationship between these comorbidities. Again, district leaders and educators must stay updated on empirical evidence. Lastly, we will discuss the nature or nurture argument for this comorbid relationship. A continuous argument in the scientific community asks for the ultimate source of characteristics and behaviors: nature, which is hereditary, or nurture, which is environment. A twin study found significant correlations of anxiety and reading disorders, but with no shared genetic cause. Another study, focusing on siblings of individuals with reading disorders, found the sibling was twice as likely to be diagnosed with GAD. Researchers suggested a shared familial risk factor between anxiety and reading disorders. The study also found a cross-concordance of reading disorder and GAD between twins, suggesting a minimal genetic risk of comorbidity. Analysis of these studies conclude a combination of both nature and nurture in comorbidity, though further research will be necessary to confirm this. Now let's look at variations in symptoms, specifically factors which influence the severity of depression and anxious comorbid symptoms with dyslexia. The severity of anxious and depression symptoms in individuals with dyslexia depend on numerous individual factors. The nature of the individual's dyslexia can in itself determine emotional advantages or disadvantages. Some types of dyslexic symptoms are more disadvantaged against healthy emotional coping. This can include attentional, memory, language, problem solving, or social difficulties. Another factor would be the severity and number of dyslexic symptoms. A dyslexic individual's typical response to adversity may determine emotional impact. Anxious and depressive symptoms specifically can be impacted by the sex of the individual, the socioeconomic status, and social, familial, and academic support. Dyslexic individuals as a whole have significantly higher mean scores of withdrawn, anxious, attention, and delinquent subscales when compared to control groups without dyslexia. However, evaluation of subscale results by sex show differences in internalizing and externalizing symptoms. Females tend to have greater internalizing factors with significant increases in mean scores of withdrawal and anxiety. Males tend to have greater externalizing factors with significant increases in mean scores of delinquent behavior. Males are also more likely than females to exhibit aggressive behavior. There is no significant effect of the total score problems scales between the sexes. The differences in sex could be due to various factors, including social gender expectations. The authors suggested increased social value and male academic achievement compared to female achievement, causing the behavioral differences. Due to the nature of externalizing symptoms, male dyslexic individuals may be more likely to receive diagnosis and intervention. Internalizing symptoms in females with dyslexia may be less apparent to parents and teachers, resulting in decreased likelihood of diagnosis. In terms of impact, females tend to be more impacted by dyslexia in academic aspects, while males tend to be more impacted in activity aspects. Another factor in the variation of symptoms includes socioeconomic status. Higher socioeconomic status typically results in greater success in terms of psychiatric symptoms during adulthood. Children in economically depraved families are more likely to struggle with internalizing problems in the future. Children of parents with borderline cognitive and significant reading difficulties also have more internalizing symptoms. Immigrant families also have increased risk of negative emotional impact. Lastly, the social, familial, and academic support can cause variations in symptoms. This is where we can act. In order to determine successful management of dyslexia and a positive psychosocial outcome, the dyslexic individuals require certain conditions in social, familial, and academic support. Long-lasting remedial work in school could help support positive outcomes. Harsh focus on academic failure can cause frustration and disengagement in the individual. One dyslexic individual was quoted saying, "To sit in a room and know that you're capable and yet not be able to show it year after year can be devastating." The student may also experience negative emotional impact in cases of inappropriate management of academic problems by parents and teachers, poor monitoring or encouragement of personal and social well-being in the education environment, and total exclusion from the classroom by means of special classes. Other factors also influence the variation in symptoms. Individuals diagnosed with dyslexia may also be diagnosed with ADHD, resulting in varied psychosocial outcomes. Late diagnosis can also have negative implications. Effective intervention can possibly reduce depressive symptoms for dyslexic individuals. Dyslexic individuals with a higher IQ also tend to receive more positive outcomes. It is important to teach individuals with dyslexia how to correctly resolve problems, as those with lesser skills in problem solving can have lasting negative emotional impacts. Now we will discuss the emotional and academic impact of comorbid relationships between dyslexia and depression and anxiety. These next 3 slides are very important as our activity will be centered on them. The vicious cycle. This all begins with an impact of poor academic performance. Dyslexia contains many symptoms which can negatively impact academic performance, including reading difficulty, linguistic, intentional, and self-regulatory difficulties, and deficits of social skills. Low academic performance generates low self-efficacy, low self-esteem, feelings of inferiority, and an impacted sense of self. Self-esteem is required for psychological health, social relationships, and emotional regulation. Especially for undiagnosed individuals with dyslexia, failure can be attributed to the self, causing learned self-helplessness. Poor academic ability are incorrectly attributed to the personal characteristics, work ethic, emotional state, or intelligence of the individual. The individual may feel that these factors are out of their control. Ultimately, the poor academic performance impacts low self-esteem. Low self-esteem is one of the most common emotional consequences of individuals with dyslexia. 80% of individuals with dyslexia reported that dyslexia impacted their self-esteem and confidence. Self-doubt and emotional insecurity causes the individual to approach academic work with low expectations for success. Individuals may give up more easily and become demotivated. These emotional consequences can become cyclical, and this results in increased failure, demoralization, poor metacognitive awareness, decreased academic interest, and decreased success. This impact repeats. Poor academic self-esteem and high academic anxiety may worsen with age, and chronic failure can result in trauma. In cases of equal academic performance in dyslexic groups and non-dyslexic groups, dyslexic students experience more negative school and social effectiveness, hope, self-esteem, and motivation in committing to homework. Multiple studies support the significant differences in feelings of academic competence. Dyslexic students also exhibit 6 times the risk of leaving school compared to their non-dyslexic peers. Now for our activity. You will be given a handout. On the handout, fill in the graphic organizer of the vicious cycle with impacts of untreated dyslexia. When you're finished, share your organizer with your peers and discuss implications of a secondary diagnosis like depression or anxiety. This activity should take about 10 minutes. Let's discuss other internalizing symptoms. Multiple studies found high rates of internalized symptoms for dyslexic individuals across all ages. They showed depressive symptoms, such as decreased happiness and life satisfaction, guilt, isolation, suicidal thoughts, anhedonia, which is loss of pleasure, fatigue, and a high external locus of control. They also showed anxiety symptoms. They also showed a poor self-identity with a strong sense of unsuitability, low levels of global self-esteem, insecurity, negative self-concept. There are social consequences, which including social integration difficulties, social problems, and comparison to performance with peers. Individuals with dyslexia also exhibit high levels of externalizing symptoms, such as disruptive behavior, high levels of psychiatric symptoms, psychosocial dysfunction, attentional deficit. One study found significant differences in externalizing symptoms of dyslexic individuals compared to non-dyslexic individuals. Now let's look at another case study of behavioral problems. One study investigated behavioral problems in 61 students aged 7 to 14 years old. 31 of the students were diagnosed with dyslexia and 30 were without a learning disability. The students with dyslexia showed higher levels of anxiety, depression, withdrawal, rule-breaking behaviors, aggressiveness, and social, attentional, and thought problems. Parents of dyslexic individuals reported more social, attentional, and thinking problems, anxiety, depression, withdrawal, rule breaking, aggressiveness, and other problems. Additional studies have supported these findings. Dyslexic individuals were reported by parents to have been involved in violent altercations twice as much as non-dyslexic individuals. Disruptive behavior, including conduct and oppositional disorders, was found to have increased in poor readers compared to normative readers. The study confirmed increased occurrences of both internalized, externalized, and depressive symptoms in dyslexic individuals. These results support the need to evaluate internalized and externalized symptoms during evaluation for dyslexic diagnoses. The study authors recommend coping strategies as a target for psychotherapeutic intervention in order to minimize these symptoms. Overall, dyslexia and comorbid symptoms can impact the overall well-being of the individual. Dyslexia can potentially negatively impact an individual's overall well-being and quality of life. Adults with dyslexia have twice the risk of emotional distress, including violence and suicide attempts. If the cycle of negative emotional impact continues, the dyslexic individuals has significantly decreased chances of success in school, jobs, and relationships. This implies long-term effects throughout adulthood. Adults with learning disabilities report 2 times higher levels of depression, anxiety, suicidal thoughts, and mental health profession visits. Dyslexia impacts nearly all aspects and functioning at work, and impact increases over time. Dyslexic individuals must put in more effort into work to compensate for reading and learning challenges, and this effort is often unrecognized by neurotypical employees and peers. Even in the 3rd or 4th decades of professional careers, learning disorders may still interfere with the individual's performance as modern culture demands extreme expectations. This is especially true for careers involving reading, writing, and calculation skills. If comorbid dyslexia with depression or anxiety remains untreated, adults can have long-lasting negative impacts and could potentially exhibit psychiatric symptoms throughout adulthood. Some adults, such as those raised in low socioeconomic status or those without a support system, are more susceptible to these negative consequences. Now let's discuss the social impacts and consequences of dyslexia and anxiety or depression comorbidity. These symptoms can impact peer relationships. Dyslexia has been frequently correlated with poor peer relationships, resulting in isolation and social rejection. These social difficulties may be caused by factors correlated with dyslexia and learning disorders, such as increased interpersonal problems, conflicts with friends, difficulty resolving social problems, increased social anxiety, depressive mood and symptoms, language and/or communication disorders, poor social skills, difficulty processing social information, low self-esteem, insecurity, and attentional and self-regulation deficits, as well as academic problems. 60% of dyslexic individuals reported feeling their reading problems had negatively influenced their relationship with peers. Many reported being teased or bullied because of their reading and writing difficulties. Other studies supported these findings, identifying significant increases in direct, including confrontational or violent, and indirect, including verbal and exclusion bullying. Dyslexic children with comorbid psychiatric diagnoses have an even greater risk of peer victimization than those without comorbidity. There is also an impact on parent relationships. One study evaluated the attachment security style between dyslexic children and their parents. This evaluates the child's perception of security with their parents, the amount of support requested during stressful situations, and ease and interest of communication with parents. The study found that children with specific learning disabilities have lower scores of expectation, increased anxious avoidant attachment, and less security with their mothers. These children also reported increased feelings of loneliness. Magnani et al. Attribute this anxious avoidant style to the mother's decreased confidence, especially in stressful situations. The mother avoids addressing the stressful event, and as a result, the dyslexic child feels more lonely, less secure, and less confident in themselves. Dyslexia can increase stress on the family, but especially the mother. Data shows mothers spend most of their time with their children, supporting them in academic, social, and emotional areas, while also dealing with their own individual emotions. Mothers predisposed to anxiety or depression are especially susceptible to this additional stress. Anxious and depressive symptoms in dyslexic children could lead to dissatisfaction, poor communication, and mistrust in parental relationships. One study reviewed parent relationship statements that high-incidence dyslexic students affirmed, including, "They do not respect my feelings. They do not accept me the way I am. They do not give me the attention I need. They do not show me how proud they are of me. I cannot rely on them. I do not get along with them." Now let's discuss treatment options to minimize emotional consequences of dyslexia. There are certain challenges of comorbid treatment. Successful treatment of comorbid depressed or anxious disorders with dyslexia will depend on individual coping, acceptance, and understanding. Comorbid conditions can be challenging to approach as there are multiple conditions on which to target intervention. Often, children with these comorbid conditions receive fragmented treatment from several providers, such as educators and psychologists, who focus on treating different conditions. This approach is speculated between researchers, but there is little support for either argument. Some specialists may target both conditions of comorbidity simultaneously. Others may target one and observe for changes in the secondary condition. There is a significant lack of empirical research and treatment options for dyslexic individuals with depression or anxiety. Most comorbid intervention efforts are focused upon ADHD and reading disorder comorbidity. There is power in diagnosis. Early identification and diagnosis of dyslexia is vital. This allows the individual to understand the source of their learning difficulty, shifting the focus away from self-deprecation and providing the opportunity to develop new strategies. Many students will find that the very label to be most empowering, freeing part of this entire process. When diagnosing dyslexia, it is important to provide detailed information of the diagnosis with academic, social, and emotional support. The individual should be provided protective factors, such as social and family support, self-advocacy tools, strength identification, and coping strategies. Late diagnosis and poor protective factors may harmfully impact the individual's development and increase the risk of psychiatric comorbidities. We will discuss multiple methods of targeting intervention, beginning with emotional health. Comorbid depression or anxiety with dyslexia can have harmful negative impacts on the individual. However, there is evidence of increased resilience, empathy, and understanding with proper support. Specialists should help the individual develop healthy coping strategies. This will ease personal reactions to learning difficulties, hopefully ending the vicious cycle of internalized and externalized symptoms. This also can ease the impact of stigma, shifting from an external to an internal locus of control. Cognitive behavioral therapy, or CBT, has been proven as an effective treatment for depressive and anxiety disorders, as well as other reading disorder comorbidities, such as ADHD and ASD. CBT, targets negative behavioral and thought patterns, and may reduce anxious and depressive symptoms for comorbid dyslexic children. Another effective treatment method for individually occurring depressive and anxiety disorders is mindfulness meditation. Studies have shown this method decreases anxiety levels in adolescents with reading disorders. And mindfulness meditation has also improved attention and word processing for adult comorbid reading disorders with ADHD. Combination of CBT and meditation has been proven to relieve symptoms of oppositional defiant disorder and conduct disorder for individuals with comorbid reading disorders and ADHD. It has also been proven to reduce anxiety for comorbid reading disorders and anxiety in adolescents. Some studies have found that when targeting anxiety with these practices, academic performance improves in adolescents with comorbid reading disorders. Another method of targeting intervention is dyslexia. Dyslexia as an individual condition is best supported through phonics-based reading intervention with strong emotional and confident support in the classroom. This is an effective method for both preventing and treating negative side effects of dyslexia. Phonics-based instruction involves systematically teaching students to assign selective attention to grapheme, phoneme associations. This opposes previous theories, such as the whole word approach, in which readers memorize entire words. Phonics-based instruction allows students to read and understand new words and has been empirically proven effective, especially for those with dyslexia or other reading disorders, but for other learning readers as well. Some authors propose that effective, empirically supported instruction for dyslexia could reduce depressive symptoms. Lastly, medical intervention. Reading disorders alone should always be approached with phonics-based instruction, not medication. However, severe or treatment-resistant individuals with comorbid depression or anxiety may require medical treatments. Some biomedical studies have considered medicated approaches to comorbid reading disorders and ADHD. In those studies, researchers examined reading progress, ADHD symptoms, and executive functions with the supplements and medications, ATX, MPH, and nutritional supplements such as fatty acids. Results showed small to medium outcome effect sizes, primarily affecting ADHD symptoms, with less consistent results for reading and executive functions. Further research is required for specific comorbid dyslexic individuals with consideration for the neurophysiological mechanisms of treatment. Most likely the best intervention method for treating dyslexia with depression and anxiety is strategic intervention. Children with comorbid dyslexic conditions may need strategic combined intervention. In treatment for comorbid dyslexia and autism spectrum disorder, intervention focuses on reading comprehension and vocabulary development, as this is an area of weakness for this specific comorbidity. De Lima et al. Suggests targeting not only the cognitive and linguistic aspects of dyslexia, but also psychological guidance for depression or anxiety. This interdisciplinary approach requires communication between health specialists and educators. This will prevent the fragmented support mentioned earlier. Though not a proven treatment method, there is evidence of improvement in education and mental health for comorbid individuals. Now, a review of important areas for intervention. Self-esteem in academia and overall confidence, especially focusing on a shift in focus upon strengths rather than weaknesses. Understanding dyslexia, depression, and anxiety symptoms and diagnosis while implementing healthy coping strategies. Building a strong social support system, including a comfortable education environment, healthy peer and parental relationships, and emotional support from specialists. Lastly, effective phonics-based reading intervention. Now we will discuss prevention methods for preventing emotional consequences of dyslexia. Though little research provides treatment and prevention options for comorbid dyslexia and depression or anxiety, one approach to preventing negative emotional consequences may be effective, and that is stigma. Stigma has extremely harsh negative impacts on both the comorbid individual and those around them. Evidence supports that stereotyping, perceptions, and assumptions about dyslexia have a greater emotional toll than the actual disability. Stereotype threat also reduces executive function. Comorbid individuals must endure stigma for both disorders while balancing the challenging symptoms of the disorder themselves. We should therefore begin reducing stigma in the dyslexic individuals, parents, educators, and society itself. Let's discuss reducing stigma in the dyslexic individuals. Many dyslexic students are trapped in a self-fulfilling prophecy by assuming perceptions of themselves, resulting in low self-confidence and ultimately decreased chances of success. This is that vicious cycle we mentioned earlier. Dyslexic individuals often report insecurity about their academic challenges and fear telling others due to negative perceptions. This results in masking learning difficulties at the expense of their own mental health and can result in decreased motivation, doubted intelligence, and an assumption of laziness. It is important to create an encouraging and welcoming society in which individuals do not have to live with this fear of being found out. We must also provide the opportunity of support for all students to discuss their academic struggles free from stigma. Now, reducing stigma in parents. Many parents of struggling students are resistant to accept labels of dyslexia and other learning disorders. This is often due to misconceptions of dyslexia's negative aspects. Celebrating strengths rather than focusing on weaknesses is important for children. Children must be taught self-confidence and comfort with familial guidance and support. In reality, ignoring academic struggles will only exacerbate the problems and can lead to long-lasting negative impacts. Educators also hold stigma. Many educators exhibit explicit and implicit attitudes of stigma. Some educators make assumptions about students with poor academic achievement, blaming low intelligence, cheating, laziness, or carelessness before the child is given a formal diagnosis. After diagnosis, some educators still believe dyslexic individuals are less intelligent or more difficult to teach. Studies have found evidence of educators' implicit attitudes, including lower ratings for writing achievement in dyslexic students. These attitudes may also appear during instruction, assistance, feedback, and nonverbal behavior. Studies have shown children notice this rejection, they feel lonelier, and they have a weaker sense of coherence. Educators serve as leaders in academia and should therefore be open to supporting all students, no matter their individual struggles. Support for educators should be provided by the school systems, specifically focusing on effective reading interventions, appropriate behaviors, and reduction of ignorance and stigma. We can reduce stigma in society itself. At large, Western society celebrates ability, productivity, and typical metrics of success, many of which rely on strong literacy skills. Differences are often ignored or condescended. Many believe that avoiding the label dyslexia altogether is an effective solution, but this is not the case. Remember, there is freedom in the diagnosis. Attitudes should be reframed to focus on areas of strength rather than weaknesses. and the public should be educated on symptoms and appropriate support for dyslexia and comorbidities. The most effective method of prevention is building a strong support system. For individuals with high incidence comorbidity, there is evidence of emotional improvement with clear communication, understanding, respect, and support from social partners. The goal of these efforts should be to build stronger relationships and socialization practices, promoting self-image, motivation to learn, and develop pro-social and communication skills. Studies show that dyslexic individuals with high incidence comorbidity improve in self-effectiveness and competence after this type of intervention. For young children, some researchers suggest circle time activities, including interactive teaching and group discussions of problem solving. This has been shown to increase self-esteem and internalize the locus of control for children with academic problems. So what do we do now? Why does this matter? Without proper intervention, comorbid dyslexic students with depression or anxiety may be caught in a vicious cycle of low self-esteem, academic fear, and helplessness. This can at times lead to severe and long-term consequences, including dropping out of school, engaging in violence, and committing suicide. There is strong empirical evidence of correlations between dyslexia and depression or anxiety. Research provides us with a picture of at-risk students and their needs, giving us the opportunity to enact real change. Though more research is needed, studies have provided us with methods for targeting treatment for these individuals, including effective education, emotional support, and strategic approaches. Long-term prevention efforts should focus on reducing stigma and building support systems. So what do we do now? For comorbid dyslexia, the obstacles have been clearly identified. It is now the role of district leaders, administration, and educators to remove these obstacles so that children with this disorder may be given the opportunity to thrive in the academic environment. This is ultimately about reducing cruelty and bettering the quality of life for children already struggling to learn and manage their emotional health. District leaders and administration should make striving efforts to create a psychological support system within the education sector, beginning with acquiring knowledgeable school psychologists and updating instructional practices. Educators should strive to connect with their students, provide them with supportive resources, and give them the opportunity for communication, growth, and learning. Thank you.